So we finished, I believe, last week with the conversation about the capillaries, right? Not last week, but 2 weeks before. Rex talks about capillaries, and I will be able to draw, actually. We'll be able to draw. Okay. You will tell me if it's discernible. I will do my best. Okay. It works. Perfect. Okay, so we're going to start our chat with the blood flow and blood pressure. Okay. So what is blood flow? Blood flow is the amount of blood that goes through a certain tissue or organ in a given period of time. And it can be measured in milliliters per minute. Does that make sense? Now, the total blood flow, the blood flow through the systemic circuit, is the same as the cardiac output. That makes sense? We're good so far? Blood pressure is the force that is exerted by blood on the walls of the blood vessels. We got it? It is measured in millimeters of mercury. Okay? Millimeters of mercury. Blood pressure is measured as the systemic parameter in the large arteries. It is proportional to the blood volume. The more blood you have, the higher blood pressure you have. Blood flows because of the pressure gradient. Does that make sense? So if you have blood, so where is blood pressure? Where is it the highest? Where? Ever the highest? Aorta. The lowest? Well, we're talking about systemic circuits, so. Farther. Entrance of right atrium, because it still has to be somewhat pressure in the vena cava. In right atrium, it's done. Okay, basically it goes from top to bottom, right? Like this. Does that make sense? Resistance. Opposition to flow. So what can the friction that blood has to overcome in order to flow through the circuit? Does that make sense? Now, few obvious relationships. Blood flow will be proportional to the blood pressure, right? The higher the pressure, the more blood will flow in a given period of time. Remember that, in a given period of time. Think about it as the faucet. You open the faucet, the more you open it, the more water will leak out of the faucet. Does that make sense? And the pressure in the faucet will be higher. Got it? But blood flow will be opposite, will be inversely related to the peripheral resistance. Sorry. The higher the resistance, the lower the blood flow. That makes sense? Now, systemic blood flow, because we're going to be talking about systemic blood pressure. Systemic blood flow is equivalent to cardiac output. We're good? Since equivalent to cardiac output, we can say that cardiac output, equals blood pressure divided by the peripheral resistance. So all in all, the final formula is that, because we really, When the patient comes to you, do you measure cardiac output? You usually don't. Do you measure peripheral resistance? Usually don't. What do you measure? Measure blood pressure. So blood pressure is proportional to cardiac output and to peripheral resistance. Does that make sense? The more blood, so cardiac output means the more blood you put in the systemic circuit in a given amount of time, the higher the pressure. We good? The more resistance the circuit exhibits, the higher the blood pressure. We good? Is that clear? Now, how can we affect cardiac output? What can we increase? Cardiac output specifically, not so much blood volume. Just immediately increases the. So stroke volume, we can affect stroke volume or heart rate. Make sense? We increase heart rate, we increase cardiac output. We increase stroke volume, we increase cardiac output. And as you will see, drugs that regulate blood pressure, some of them actually target cardiac output. Okay? Now, resistance. What determines peripheral resistance? Blood viscosity. Okay? So this, hematocrit. High hematocrit leads to the elevation of blood pressure because more viscous fluid is harder to pump through. Does that make sense? Vessel length. It doesn't happen overnight, but in people with the bigger body, okay, they have more blood vessels, significantly more blood vessels, and they usually demonstrate higher blood pressure. Okay? Flow turbulence. I'm going to do the highlighter again. Flow turbulence. This is the example right here of the laminar flow versus turbulent flow. Laminar flow is smooth and there are no whirlpools or something. Turbulent flow is when the direction of the flow starts to change, it goes backwards and so on and so forth. Does that make sense? You can see, like, if you go to the river, if you look at the calm, slow moving river without any big boulders or something, that's the example of laminar flow. You look at the mountain river, a lot of turbulence. Does that make sense? Now, in blood vessels, turbulence will be formed mainly by the atherosclerotic plaques, any type of stenotic narrowing of the blood vessels, and it is also will be formed at the branching points. When blood vessels branch, that's where the turbulent flow starts to influence. Does that make sense? Now, these three factors, turbulent flow, length of the blood vessels, and viscosity of the blood, they do contribute to the blood pressure. But the main problem with them is that you cannot regulate them right away. What you can change is the vessel diameter. Does that make sense? Vessels can be dilated, they can be constricted. This is a pretty fast process. How resistance is related to the vessel diameter, or radius for that matter. This is the little formula here at the bottom. I don't know if you can see it, it's pretty small. But let me give you a perspective. Peripheral resistance is inversely proportional to the vessel diameter taken in the power of 4. Let me decipher this for you. If you change vessel diameter twofold, say you have a blood vessel with a diameter of 100 micrometers and you constrict it to 50. So you decrease the diameter 2 times. What's going to happen to the resistance in that vessel? Is it going to go up or down? It's going to go up. How much? Two in the power of 4, which is 16. Does that make sense? Because it is inversely proportional, not just to if you would say, like, if it would be just inversely proportional, then it would be 2 times. You understand what I'm saying? Or not? Well, okay. Say diameter is 2, okay? Diameter of the vessel is 2. So peripheral will be 1 divided by 2 in the power of 4, which is what? 1 divided by 16. Does that make sense? I take generic numbers. You constrict the vessel, so 1/16, whatever. You constrict the vessel from 2 to 1. Okay? So what's going to be peripheral resistance? 1 divided by 1 in the power of 4. 1 in the power of 4 is what? 1. So peripheral resistance will go from 1/16 to 1. Peripheral resistance will essentially increase 16 times. Does that seem more plausible? Okay, good. So what I'm trying to tell you is that by regulating the diameter of blood vessels, we can influence the peripheral resistance enormously. And we can change the diameter of blood vessels almost instantaneously. Got it? Questions? Moving on. So, blood pressure is generated by the peripheral resistance, essentially, because heart is pumping blood, generates flow. Flow is opposed by the resistance that generates the blood pressure. Sorry. Okay? This graph on the right side shows you the blood pressure in different parts of the circulatory system, in different parts of the systemic circuit. It is highest in aorta, and then it declines through the muscular arteries and arterioles and reaches fairly low numbers in capillaries and even lower in venules. Does that make sense? Now, this drop, the steepest drop in the blood pressure happens in arterioles. This is why, so this part, the steep drop, that's arterioles. Does that make sense? This is called, that's why arterioles are called resistance vessels. So they actually regulate the resistance of systemic circuit. Does that make sense? Okay. Now, blood pressure, as you can imagine, blood pressure closer to the heart will fluctuate from systolic to diastolic, systolic being higher, diastolic being lower. Does that make sense? Systolic normally is about 120. Diastolic is 70 to 80 millimeters of mercury. I'm not going to use units anymore. Is that okay with you? We all know that it's millimeters of mercury. I'm just going to use numbers, right? Now, a few terms. Difference between systolic and diastolic is called pulse pressure. Okay? Now, using 120 over 80 all the time is somewhat inconvenient, especially in terms of physiological measurements and comparisons. So scientists often use mean arterial pressure, which is diastolic plus 1/3 of a pulse. Let's say you have a patient who is pre-hypertensive and has systolic at 140 and diastolic at 80. What's the pulse pressure? So systolic is 140, diastolic is 80. So 60 is the pulse pressure. What's 1/3 of the pulse pressure? 20. So his mean arterial pressure will be diastolic, which is 80, plus 1/3 of a pulse pressure, 20, 100. Does that make sense? This is called mean arterial pressure. Please know the way we calculate it. Does that make sense? If you would look at the pressure in the capillaries, it's pretty low. It drops from 35 to 17. Capillaries are fragile, so they cannot withstand high blood pressure. Does that make sense? So you have to this is why it is so important that arterioles are before capillaries. Because arterioles can essentially maintain the constant blood pressure in capillaries and prevent the damage. Does that make sense? Venous pressure is practically constant. It's about 15 millimeters of mercury. Veins basically have very little resistance. They're wide. There's not a lot of, since the blood flow is slow and stagnant, there's not a lot of friction generated, so resistance is low. Now, if you remember what we just 5 minutes ago said, the driving force for the blood flow is the pressure gradient. Does that make sense? Basically, when you've heard about blood transfusion, right? You gave blood, correct? What is the vessel that the blood is taken usually from? Vein, yeah. Right, and they hang the bag down. Can you do direct person-to-person blood transfusion? Hypothetically, yes. What's the main problem? Can you do vein-to-vein? No. Why? No pressure gradient. Pressures are equal. So how would you do person-to-person direct blood transfusion? What do you need to do? Artery to vein. And hitting the artery is hard. Okay, so that's one of the big problems, the direct. It can be done, but it's not easy. Okay? That makes sense? So, but now we face a problem, because if this pressure gradient is what drives the blood flow, and the pressure gradient in veins is pretty low, how can blood still flow through the veins? Turns out there are several mechanisms that propel the blood through the veins. 2 pumps. One is muscular. When muscles contract, they squeeze the veins like we squeeze the tube of toothpaste and to move blood towards the heart. That makes sense. What ensures that the blood flows actually towards the heart? Valves. Venous valves prevent the backflow. They look like semilunar ones. Does that make sense? So if blood tries to go back, they don't let it. Respiratory pump is also very interesting. It is secondary in its role in terms of, venous propulsion. Think about this. When you inhale, like this, you expand the chest, which immediately drops the pressure in the thoracic cavity. And you squeeze the abdomen, which increases the pressure in the abdominal cavity. Increased pressure in the abdominal cavity will push the blood towards lower pressure in the thoracic through the vena cava. Does that make sense? As you can imagine, the main problem in, moving blood through the veins is to get it from the limbs, from the lower body. It's not a big deal, with the upper part, right? Does that make sense? Good? Moving on. I want to remind you about the blood pressure regulation. We can do a few things. First, we can do cardiac output, which is stroke volume or heart rate. We can do peripheral resistance, and we can do kidneys. Okay? That makes sense? So short-term fluctuations, short-term changes, they focus on the cardiac output and peripheral resistance. Long-term responses, long-term changes in the blood pressure, they come from kidneys. They come from changes in the blood volume. So let's take a glance at regulation of blood pressure. And again, this is the part, related to the exam. When we will talk, what happens when you increase cardiac output, blood pressure will increase, decrease. When we decrease the heart rate, blood pressure will increase, decrease. So, in exercise, see what happens. Muscular pump, activity of it goes up. Activity of respiratory pump goes up. So venous return goes up. Since venous return goes up and diastolic volume goes up, stroke volume goes up, cardiac output increases. Make sense? Sympathetic activation, when you exercise sympathetic activation, will lead to the constriction of the blood vessels. Blood pressure will go up just immediately. That makes sense? What if you just have a lowered blood pressure? Say blood loss. Okay? This immediately increases sympathetic stimulation of blood vessels and the heart. Sympathetic stimulation of the heart will increase the contractility of the cardiac muscle, which will drop ASV and increase the stroke volume again. Okay? Epinephrine will stimulate the heart to beat faster. Increased heart rate will increase cardiac output and increase blood pressure. Does that make sense? So it all comes down to stroke volume or heart rate. Sympathetic stimulation will increase stroke volume, will increase heart rate, will increase cardiac output, will increase blood pressure. Does that make sense? Exercise will increase blood pressure both through the sympathetic stimulation and through the increased venous return. Does that make sense? Now, that is immediate sort of regulatory mechanisms. Now, if we will dive a little bit more detail, in more details of those regulatory mechanisms, as you can imagine, and we talked about it in the very beginning of the course, many responses in the body are regulated via reflex arches. And cardiovascular responses are regulated by reflex arches as well. Reflex arch starts with what? Hmm? In order to produce response. Huh? Stimulus, yeah. You got to start with the stimulus, right? So, stimulus in case of change in the blood pressure will be stretch of the blood vessels. Are we clear about it? The stretch of the blood vessels is sensed by mechanoreceptors. Okay? Mechanoreceptors will send the signal, a afferent input, to the medulla oblongata. That makes sense? So say blood pressure in me drops. We have two major sites of baroreceptors. It's the aortic sinus and carotid sinus. They will send signals to the medulla. In medulla we have two centers. Three. Okay, three centers. First of all, we have cardio-inhibitory center. What does it do? Cardio-inhibitory. Inhibits what? Cardio-inhibitory. If it's cardio-inhibitory. It inhibits which organ? Heart. It inhibits heart, right? It slows it down. Does that make sense? Cardio-acceleratory increases the heart rate. Does that make sense? Now, cardio-inhibitory, that slows down the heart. Is it a part of sympathetic or parasympathetic system? Parasympathetic. Okay? Cardio-acceleratory, sympathetic. Now, cardio-acceleratory will not only speed up the heart, it will also make the contraction more forceful. Does that make sense? Do you understand what I'm saying? So that's the effects on the heart. What about blood vessels? Which system controls blood vessels? Entirely sympathetic. Blood vessels are under entirely sympathetic control. So if your blood pressure drops, what's going to happen to the blood vessels? They're going to constrict. This is controlled by the vasomotor center in the medulla. Does that make sense? Now, if your blood pressure increases, what's going to happen to blood vessels? They're going to dilate. How? What's going to happen to vasomotor center? It's going to inhibit it. Perfect. That's why I love cardiovascular system. It's extremely logical. Okay? That makes sense? Now, what I want you to remember very clearly, cardio-acceleratory and vasomotor centers are under sympathetic control. Cardio-inhibitory center is under parasympathetic control. That makes sense? Which makes perfect sense, really, because you don't need to drop the blood pressure from normal levels usually. I mean, if you like in the resting state, you don't need to go in hypotension. You're in the resting state already. Does that make sense? And if you're excited, there are plenty of opportunities to slow yourself down. That's why there are so many ways to increase the blood pressure, and basically the only way to decrease it is either stimulate, you stimulate parasympathetic or inhibit sympathetic system. Okay? Now that's going to be nervous control via the reflex arch. Are we clear about reflex arch? Can you play with this? Okay? Chemical controls. If you have increased carbon dioxide in the tissues all over the place, what do you need to do with carbon dioxide? Get rid of it. How? You need to deliver it where first? Lungs, as fast as you can. So since you need to deliver it to the lungs as fast as you can, what do you need to do with the blood flow? increase. How blood pressure is related to blood flow? To increase blood flow, you need to increase blood pressure. Does that make sense? So elevated carbon dioxide will trigger the response to increase blood pressure. That makes sense? Decreased pH will trigger the same response. Why?
CO2 is probably what makes it acidic, and so you're going to exhale the CO2 and increase the pH.
Excellent. CO2 is our best way to quickly get rid of acid. We exhale CO2, pH of the blood increases to normal. Does that make sense? So if we have like acidosis, blood pressure will go up. Does that make sense? Blood pressure will go up to increase blood flow, to deliver more CO2 to the lungs so we can exhale it. Does that make sense? And the last is oxygen. Oxygen has the least important role in blood pressure regulation. However, the steep drop in oxygen levels will increase blood pressure too. Does that make sense? Good. So, hormonal. Which hormones I absolutely want you to know? Epinephrine, norepinephrine. This is clear, people. Come on, that's sympathetic, okay? So just remember, norepinephrine, epinephrine, sympathetic activation. What they're going to do to the heart? Heart rate increases, what else? Heart specifically. So heart rate goes up and contractility goes up, okay? What they're going to do to the blood vessels, epinephrine, norepinephrine? They're going to constrict blood vessels. Epinephrine, to less extent, will constrict blood vessels in the muscles, but that's details, okay? We don't need to go into those details. We're good? So that's, I kind of count it as one hormone. Second, ADH, antidiuretic hormone, also called vasopressin. What does it do? Vasoconstrictor. It does a lot of other fancy things, but it's vasoconstrictor. Make sense? Good. Atrial natriuretic peptide. Vasodilator. Okay? Does that make sense? It's weak vasodilator. And angiotensin 2. Angio, the word angio refers to what? Blood vessels, yes. So angiotensin constricts the blood vessels. Epinephrine, norepinephrine, angiotensin, and ADH, vasoconstrictors. ANP, atrial natriuretic peptide, is a weak vasodilator. We good? And finally, hypothalamic hormones. Not hormones, sorry, hypothalamic regulation. I'm sorry, I apologize. Hypothalamic regulation. Here's what I want you to understand about hypothalamus. Can you consciously force your heart to beat faster? No. But what happens if you are entering the exercise room and you start exercising? You may not even start the movement yet. Your heart rate will go up right away because cortex already sends the inputs to the hypothalamus that we are about to be active, increase the heart rate preventatively. Does that make sense? So it's kind of partially, conscious. I mean, not really, but sort of. Does that make sense? That's all you need to understand. So it's kind of hypothalamus receives the input from the cortex about upcoming activities and increases the heart rate. Okay. Now these pictures, they show you here, the The increase in blood pressure, vasodilation, slowing of the heart, okay? Decrease in blood pressure, vasoconstriction, speeding up the heart. And baroreceptor reflex shouldn't be a problem. CO2 regulation, pH, that you need to know. Good? Clear? So if I ask, how does decreased pH affect systemic blood pressure? You tell me it increases it. Okay.
Would somebody with COPD who's no longer on a cardiac sleep drive, would the oxygen level increase blood pressure more, like a lower oxygen level increase blood pressure more so than it would in a non-healthy person?
Oxygen saturation, the reason why it has the lower influence on the blood pressure is because it's actually, when we say oxygen saturation, we refer to the amount of oxygen that is bound to hemoglobin. And the unloading, we have a lot of oxygen that is constantly bound to hemoglobin. We have a huge oxygen depot. Does that make sense? So if we go really low on oxygen, we always have a reserve that can be unloaded in the tissues. So on the very basic sort of primitive level, we can say our body doesn't really care about oxygen levels in the blood that much. That makes sense? Because it always has a depot. Did I explain it? We'll get to the depot. We didn't talk about hemoglobin yet, but we'll talk about it and you will see there's a huge depot. Okay? Now, renal mechanisms of the blood pressure regulation. So, direct mechanism. What do kidneys do? They filter. If you ever worked with filters, the more pressure you exert on the filter, the faster it's going to filter, the more filtrate it's going to produce. Does that make sense? Your blood pressure goes up. It's called direct mechanism. Blood pressure goes up, more blood is filtered through the kidneys, more urine is produced, you urinate more, you drop the blood volume, blood pressure goes to normal. Does that make sense? This is a very fast mechanism, and it's called direct because no hormones are involved. And obviously, say blood pressure drops, you lose water or you lose blood, okay? What's going to happen to urination? It's going to decrease, yeah, until your blood pressure / blood volume will be restored. Does that make sense? That's a direct mechanism. Now, indirect or Renin-Angiotensin-Aldosterone system. We talked about it already. It responds exclusively to low blood pressure. Low blood pressure. So blood pressure low, renin gets activated. Okay? Renin converts angiotensinogen into the angiotensin 1. Okay? Angiotensin 1 is converted in the lungs. No, wait a minute. Just want to remove it all. So angiotensin 1 is converted into the angiotensin 2. Angiotensin 2 stimulates aldosterone. Aldosterone increases retention of which ion? Sodium. Sodium stays in the body, water follows. Sodium, blood volume increases, blood pressure is restored. Does that make sense? Isn't it awesome? You know why it's awesome? Did anyone get ever bitten by a viper? I hope not. What is one of the biggest problems? Well, yeah, when you're bitten by a viper, physiologically. Blood pressure drops very significantly. One of the treatments actually that is recommended, not treatments, but sort of if you have a patient on your hands who you need to bring to the hospital, and the patient is suffering from the viper bite, coffee. To stimulate the heart. To just it's not going to cure the person, but at least it's going to keep the person alive and not send the person to a shock until the person arrives to the hospital. Does that make sense? So, scientists, these dudes, don't memorize the names. Basically, they thought, okay, if we have this amazing thing, if we have venom, a viper, that tremendously drops the blood pressure, can we use it as a drug to treat hypertension? They managed to isolate the compound, which was called Captopril. It's on the right, okay? And Captopril is ACE inhibitor. It inhibits angiotensin converting enzyme. Basically, it stops the Renin-Angiotensin-Aldosterone system at the step of angiotensin 1. That's it. Doesn't go anywhere else. Blood pressure decreases. Does that make sense? I mean, it's a good drug. There's some interesting data about clinical studies, and turns out it's not in terms of treating chronic hypertension, nothing works better than thiazide diuretics. Anyway, ACE inhibitors are okay, but thiazide diuretics are the first choice. But nevertheless, those fellas, they got Lasker Award, which is really a big prize in physiology and medicine. Okay? Now, this is sort of a summary of blood pressure regulation. There's a lot to talk about, but I just want to highlight a few things. So first, physical activity, okay? Venous return goes up, stroke volume goes up, blood pressure goes up by cardiac output. That makes sense. Decreased release of atrial natriuretic peptide. Sodium stays in, water stays in, blood volume goes up. Actually, you know what? How about this? Let's model responses, blood pressure responses to the blood loss. Okay? So somebody loses 2 pints of blood. It is not lethal. The person is patched up. Okay, no blood loss anymore, just 2 pints of blood. So blood volume goes down. Blood pressure goes down. Stretch of the blood vessels decreases. They're not as stretched anymore. So it initiates which reflex? Baroreceptor reflex, right? So that low stretch, that signal goes where? Which part of the brainstem? Medulla. It goes to the medulla. In medulla, remember, stretch is low. Which centers it's going to activate? Cardio, acceleratory, and vasomotor. So cardioacceleratory, how is it going to respond to the heart? Increased heart rate and contractility. Contractility increases stroke volume, heart rate, okay? So they both increase cardiac output. Makes sense. Since blood loss is usually associated with a vasomotor center, what is it going to do to the blood vessels? Constrict. Since blood loss is usually associated with a lot of stress, which hormones are going to be produced? It's a long term. In the short term, like immediate hormone of stress. Medulla, adrenal medulla. Adrenaline. If it's adrenaline, we call it epinephrine, norepinephrine now, right? What do they do to the heart? Stimulate it, speed it up, increase contractility. What do they do to blood vessels? Constrict them further. Does that make sense? So you have sympathetic activation overall. Okay? Now, since the blood volume decreases, blood flow through the tissues goes down. What happens to the concentration of CO2 in the tissues? It increases because we can't get rid of it. Does that make sense? CO2 concentration increases, pH decreases, becomes acidic. That's going to be your chemical stimulus that will increase the blood pressure. Does that make sense? What else did we forget? Hormones. Low blood pressure activates in the kidneys renin, right? Renin activates angiotensin, angiotensin activates aldosterone. Aldosterone will cause the retention of sodium. Sodium stays in the body and keeps what in? Water. When your blood volume goes down, well, we kind of didn't talk about it, but hypothalamus senses the lower blood pressure and produces a special hypothalamic hormone that gets into the posterior pituitary and then released from here. When your blood volume is down, what you do less? Physiological activity that is very noticeable. Huh? You sweat less, but more like noticeable. Kind of trying to point at the body region. Urinate, yeah. Urinate less, right? Both due to the lower blood pressure, direct mechanism, and due to the fact that you have ADH produced. Does that make sense? And diuretic hormone will directly keep water inside. Does that make sense? Actually, it will also cause thirst. You will start drinking and you will restore the blood volume. Does that make sense? So if you will just, this is what's lovely about it. Because you just go for every stimulus and you immediately see what happens to the systemic responses. Does that make sense? Well, body size increases the length of the blood vessels, and dehydration increases the viscosity. That makes sense. There will be basically questions like, what happens, when your blood volume goes down? What happens to the renin system? What happens to angiotensin, and so on and so forth? Okay? That's what you have to focus on. We're good. Questions? Measuring. Pulse. Those red points are the points where we measure pulse. Pretty much pressure a major artery against something. Ideally against the bone. So brachial artery, that's the pulse right here. When you check for the vital signs of a person, is the pulse a reliable measurement? If you cannot detect the pulse, does it mean that the person's dead? No, probably you just cannot detect the pulse. I mean, it's just really hard sometimes. Okay? So we basically measure the pulse in the elastic arteries, large arteries that stretch and recoil back. Okay? Now, systemic blood pressure. Ideally, where should we measure it? Ideally. Well, ideally, we should measure it in the aorta. But that's going to be a terminal measurement, right? I mean, that's it. The next available point, so the closer it is to the heart, the better. So I would argue it's not brachial artery, it's carotid, but it's also terminal. Or really, going to be skewed by the process of suffocation. So brachial artery is the best point. If not brachial, where would you measure blood pressure? Femoral. Yeah, you would measure in the femoral. So here's how you do it. You go to Walgreens, buy the thing for $60 and it does everything for you and you're good. Okay? Seriously speaking, you put the cuff on the brachial region and you pump it to a very, very high pressure point, say 200. What happens at this point with the brachial artery? Huh? Yeah, it's collapsed. It's completely collapsed because that pressure just collapses the arteries. There's no blood flow. You need to start to release the pressure, right? You release the pressure, and at the same time, you listen to the sounds in the brachial artery in an antecubital region, so-called cortical sounds. When they appear because the systolic pressure is higher than the pressure in the cuff. Does that make sense? That's the time blood flows, okay? And that's your systolic pressure. When they disappear, that's diastolic pressure because at this point, blood flows smoothly, okay? It's pretty neat. When I learned how to do it, I could do it like the whole day. I loved it. Clinically, blood pressure changes all the time. If you exercise, it goes up. Okay, if you're getting older, it goes up. If you're a female, it's usually lower. Okay. If you're angry, it's higher. So transient changes are normal. Okay. Hypertension is considered the blood pressure. Systolic is higher than 140, diastolic is higher than 90. Normal blood pressure is 120 over 80 over 70, something like that. Between is the pre-hypertension state. It's kind of shown here, okay? So that's hypertension. This is pre-hypertension. That's green is normal. Two types of hypertension, primary and secondary. So primary is basically the killer, kills American population. Smoking, atherosclerosis, obesity, type 2 diabetes, which impairs the function of blood vessels. Secondary hypertension is due to other causes, say renal failure, okay? Renal failure may lead to hypertension. In this case, hypertension is secondary because the main disease is renal failure. Does that make sense? Okay, or say Cushing's, okay? Increased production of corticosteroids. Blood pressure goes up, yeah. But blood pressure goes up because somebody's adrenal glands produce too much cortisol. Does that make sense? Treatment of primary hypertension. As we mentioned, you can do blood volume, right? Diuretics. You can do ACE inhibitors. Usually ACE inhibitors are for the acute control, like spikes in blood pressure. Like, say, my mom, she's hypertensive, but usually she keeps blood pressure under control, but as any mom, she worries all the time. So when she's extremely worried, the blood pressure spikes and she has to take some additional pills to bring it back to normal, okay? So ACE inhibitors, beta blockers. They decrease sympathetic stimulation of the heart and decrease contractility, decrease the heart rate, decreasing systemic blood pressure. Alpha blockers. They dilate blood vessels. There's an ongoing There's no final answer, as you know. There's an ongoing battle. Should you decrease high blood pressure in pre-hypertensive people? Are there significant benefits? Basically, the bottom line, if you have a patient in any clinical study, you're looking at the intervention and you're looking at the outcomes. Does that make sense? So say if you would study a drug that treats hypertension is in people over 60, and you would choose the endpoint of the study as the 30-year survival, that would be a lousy endpoint because they're all going to be dead, the majority of them, in both groups, just because they're over 60. There are very few people that can live till 90. Does that make sense? So if you would look at the risk of cardiovascular disease or risk of adverse cardiovascular event, which would include myocardial infarction or stroke, major thing, or death due to the cardiovascular event. And you would compare a group of people who are very hypertensive and people who are not so very hypertensive, then you will see that treating hypertension is good. If you have a patient with 200 over 160, yeah, this patient should be treated. If you have a patient with 140 over 100, will it increase the risk for this patient or the cohort of patients? Yes. Will it decrease the risk? Yes. Will the decrease be as substantial as for really hypertensive people? No. Do you understand what I'm saying? Like, if somebody is very obese, losing weight is really good. If somebody is overweight, then losing weight will not provide such enormous health benefits. That makes sense? So it's still like in the works. Should we give those people treatments? Should we give them drugs? Is that like medically warranted? What about side effects and so on and so forth? It's kind of weird. Hypertension. Low blood pressure, 90 over 60. It's kind of good because if you're hypertensive, you have sort of some wiggle room later in life. So maybe by the age of 70, you're going to be normotensive. Unless it's chronic and has some underlying causes, it's not a reason to be worried. Orthostatic hypertension is the condition that everybody experienced, I believe. When you lie down and you very quickly stand up, you get dizzy and can fall down because of the immediate decrease in blood flow to the brain. Chronic hypertension, like Addison's disease, underfunction of adrenal glands. Okay? Acute hypertension is the circulatory shock, which we're going to talk about now. Now, again, it's not, generally it's considered this way. If it doesn't affect your day-to-day performance, you're fine. I know people who normally hypertensive, say they have 100 over 60, and it's kind of a higher end. They may, like in the morning, they may have 90 over 60. Good for them. Okay. Now, this is, I like this scheme because it shows you what happens during the blood loss. And we covered it already. Okay? A lot of it. So, blood loss. Massive blood loss. A lot of blood is lost. So again, when you lose blood, what's going to happen to the heart rate? It's going to increase. So tachycardia, right? What's going to happen to the diameter of blood vessels? Decrease. They're going to constrict. All of them or some are going to constrict more than others? Well, which ones you do not want to constrict at all? They can't really constrict. Which muscular arteries you don't want to constrict? Well, first and foremost, brain. Anything that runs to the brain, so it's going to be vertebral, for instance, okay? Carotid. You don't want coronary arteries to constrict because it's hard. What can you spare? You can spare skin. Become pale. That makes sense? Now, since you lose a lot of blood, the blood flow through the tissues, all tissues, does it increase or decrease? You lose a lot of blood. Blood flow decreases. So if it decreases, what happens to the CO2 and acid? It starts to accumulate in the tissues, right? So how can you get rid of it? Heart rate, blood flow. The only way to increase blood flow by now is heart, so you tachycardic. You also have to get rid of that acid. Start to breathe. Okay? You try to breathe out that CO2. Does that make sense? Urine output goes down because of the direct mechanism, and ADH is released and renin system is stimulated. Does that make sense? Now, ADH promotes thirst, so we'll start compensating by drinking fluids. Does that make sense? However, since carbon dioxide accumulates in tissues and they become acidic, neuronal activity, if you don't get rid of that CO2, neuronal activity will be depressed and eventually you can slip into coma. Okay? Because acidity impairs the ion transport in neurons. Now, hopefully, imagine you have a patient, you stop the bleeding, you gave fluids to the patient will recover. Bone marrow will produce new red blood cells, liver will churn out plasma, everything's going to be good. Now imagine for a second, you have a patient who lost like 3 liters of blood. Blood pressure tanks, not just tank, like 60/40, okay? In this case, perfusion of cardiac muscle goes down, right? So cardiomyocytes, cardiac muscle, doesn't receive enough nutrients and oxygen. First, it switches to fermentation. It damages cardiomyocytes and it cannot perform as well. So contractility of the heart goes down, blood pressure goes down, perfusion of the heart goes down, blood pressure goes down, and it becomes a positive feedback, which leads to death. This is shock. Okay? This is called hypovolemic shock due to the blood loss. If you have, again, I'm not a doctor, not technically qualified to provide treatments, but from the good, just physiological common sense. If you have a patient with a blood loss, severe blood loss, what do you need to replenish? Do you need to give the patient blood? Blood, no. What do you need to give? Fluid. Because if you provide enough fluids that you will prevent hypovolemic shock, patient is not going to feel well, but at least you will be able to stabilize the patient until, the patient, not it, but he or she can receive the actual, red blood cells, okay? Actual transfusion. Does that make sense? Fluids are the most important. And actually, studies of artificial, there were studies of artificial blood artificial blood provides no benefit over the isotonic saline. Was shown multiple times. Okay. Now, vascular shock. Massive vasodilation. Observed in patients with allergy. The anaphylactic shock, people who experience anaphylactic shock, they die not only because of the obstruction of the respiratory passages, they die because of the massive vasodilation, which leads to steep drop in the blood pressure and then cardiac insufficiency. That's it. Also, it's a seepage of plasma into the tissues and so on and so forth. Does that make sense? And cardiogenic shock, when heart cannot pump normally, say somebody experiences massive myocardial infarction, okay? A huge chunk of the heart is dead. Heart cannot sustain the proper blood pressure in the system. That's it. It's cardiogenic shock. So know the principles of those three shocks. Good? Let's take a break, and when we'll come back, we'll chat about quiz and we'll chat about